I want to welcome everybody to Selling's first webinar. My name is Gregory Benedetto. I'm joined by Dr. Mitchell Sheinkop and Ted Sands. We want to thank you for taking time out of your schedule to be with us tonight. We are excited about this program. It's one of many that we're going to be conducting, hopefully every month, where we'll have different specialists speaking every month about different specialties. Particularly with the use of autologous stem cells and PRP, how they're used in different procedures, how they are delivered, and the overall efficacy, and really how we can get better at using the science to help people and maybe, even prevent some surgeries along the way. I myself have been with Selling for about 7 years. I've been involved in over 1,000 clinical and OR procedures involving stem cells and/or PRP, from foot and ankle to spine to sports. It's been a very interesting journey, and I've absolutely loved my time here. We're being joined, like I said, by Ted Sands, PhD. Ted has a degree in microbiology and a PhD in biochemistry. He's worked with various industries, including, in industry with various companies, including J&J, VetStem. He is one of the most brilliant men I've ever met, and I really enjoy working with him. He has a real knack for just seeing things and has a real talent for writing papers, and which is an impressive skill. And I, for one, am very privileged to get to learn from Ted. Our keynote speaker tonight is Dr. Mitchell Sheinkop. Dr. Sheinkop comes to us from Chicago Medical School. He is a orthopedic surgeon based in Chicago. He was the former director of the Joint Replacement Program and a professor emeritus at Rush University. We consider him a leading authority in the treatment of patients with complex hip and knee disorders. He has pioneered some new procedures, including computer-assisted navigation, minimally invasive technologies, and even more so now, regenerative medicine. And that's what we're here to talk about today. His experience, his ability to help people with these procedures that we here at Selling believe is a paradigm for our company, where we were trying to prevent surgeries before they happen. To begin, Ted Sands is going to give us a small little overview of some of the literature out there. So without further ado, I will turn it over to Ted Sands. Go ahead, Ted.
Thank you, Greg. I will review 3 recent papers in which bone marrow concentrate was used to treat knee OA. And I'll start with a publication by Dr. Sheinkop, on which I am a co-author. It was published in 2020. It was entitled Clinical Outcomes and Safety of a Combined Autologous Bone Marrow Concentrate, Intraosseous and Intraarticular Injection for Knee Osteoarthritis at 12 months. Enrolled patients had a diagnosis of knee OA. Kelvin-Lawrence score had an average of 2.9, meaning most of the patients had a Kelvin-Lawrence score of 3. And the KS of the Knee Society score was greater than 60 upon enrollment, but out of a 100-point scale. The BMC that was obtained from 60 mils of BMA was processed in an ART BMC Plus device. Generally, when you process bone marrow concentrate or whole blood, bone marrow aspirate or whole blood, you end up with a layer called the platelet-poor plasma. Generally, that's discarded. But in this Plus device configuration, the PPP can be routed internally with no sterile breaks and concentrated in about 30 seconds. Dr. Sheinkop chose to concentrate the patient's PPP and then combine that concentrate with 20% of the BMC to inject via the intraarticular route, and the remaining 80% of the BMC was injected via the intraosseous route into the tibial plateau. Clinical outcomes for the study from baseline to 1 year showed a decrease in VAS of 2.6 on a 10-point scale. The Knee Society score knee function and knee score, went up almost 15 points. The knee society score function went up almost 12, and the lower extremity function score went up approximately 16 points. The change in VAS and the change in the lower extremity functional score both exceeded the published minimum clinically important difference and demonstrating a clinical benefit at 1 year. And now I'll turn to reviewing two publications by Dr. Philippe Benedetto. He has pioneered the treatment of musculoskeletal lesions starting in 1989, treating with bone marrow concentrate. In 2020, he published a paper entitled Human Bone Marrow Mesenchymal Stem Cell Injection in Subchondral Lesions of Knee Osteoarthritis, a prospective randomized study versus contralateral arthroplasty at a mean 15-year follow-up. 140 patients that had comparable pain and a reduced quality of life in both knees and had been and were eligible for TKA replacements were enrolled in the study. Bone marrow concentrate was delivered by the intraosseous route into the femoral condyle and the tibial plateau in a randomized knee. So there was randomization, prospective randomization, and then the other knee underwent a TKA, both of which occurred during the same surgical procedure. At the 15-year milestone follow-up, 21 TKA knees required revision. 25 BMC knees had progressed to the TKA with an average of a 10-year average time to TKA. So, in other words, there was a delay in the progression to TKA in the patients receiving a BMC intraosseous treatment. And according to the paper, the two rates of TKA or conversion to TKA or revision, they weren't meaningfully different at the 15-year point. Two notable clinical outcomes were the cartilage volume increased at 2 years and the bone marrow lesion volume decreased at 2 years. And bone marrow lesion volumes associated with increased pain. Dr. Inigo then followed that TKA versus BMC publication with a publication in 2021 entitled Subchondral Bone or Intraarticular Injection of Bone Marrow Concentrate Mesenchymal Stem Cells in Bilateral Knee Osteoarthritis. What better postpone knee arthroplasty at 15 years? A randomized study. 60 patients with comparable bilateral knee OA were enrolled, and there was a randomization of the intraarticular treatment into one knee, and the other knee would receive the intraosseous treatment. Both treatments were performed during the same surgical procedure. 155 mils of bone marrow was used to create the bone marrow concentrate. 20 mils was injected via the intraosseous route, and 20 mils was divided between the femoral condyle and tibial plateau compartments via the intraosseous route. Comparisons were made at 2 years. The VAS improved for both cohorts out to 1 year, but only the IO cohort had a stable VAS at 2 years. In other words, the IA cohort decreased. The KSS scores were similar baseline, and at 2 years, the IO cohort had a 79.3 score, while the IA cohort had 64. Joint space narrowed for IA cohort, but not the IO cohort out to 2 years. And again, cartilage volume at 2 years was found to be increased, and the bone marrow lesion volume had decreased also at 2 years. The comparisons at 15-year follow-up, 20% of the IO cohort progressed to a TKA with an average time to TKA of 14 years. 70% of the IA cohort knees had progressed to TKA with an average of 7 years. So the difference in the rate to TKA between the IA route of treatment and the IO route of treatment was 3.5-fold higher for the IA route. But both of these approaches demonstrated a delay in the progression to TKA, meaning that there was management of the osteoarthritis, a diminution of the impact of the progression of osteoarthritis, whether you got an IA treatment or an IO treatment. And then at 15 years, the Knee Society scores for the survivor knees in the IO cohort was 76.2 and 58.4 for the IA cohort. And that's the summary. Over to Dr. Sheinkop.
Thanks, Ted. I think the importance of Ted having reviewed those 3 articles with you is to emphasize everything we're going to tell you tonight is based on scientific evidence. We have an evidence-based initiative here, and that's why I want to emphasize the importance of those articles. Now, I'm going to get into the practical aspect of the practice of orthobiologics. When I meet a new patient, the first thing I'm interested in learning is, why are you here? What are your symptoms and what are your functional limitations? Number 2, your medical comorbidities. It's important to understand if this is a healthy patient or if it's a patient who has problems with diabetes or other medical issues that require attention. Those comorbidities may influence whether you're going to use an anesthetic or whether it's going to be done under local anesthesia. Next, I want to know the history of intraarticular injections. If the patient had a steroid injection in the last 3 months, I'll accept a hyaluronic acid injection within the last 6 weeks. Now I want to know about the patient's requirement for prescription meds because it gives me further insight in the patient's overall health profile. We want to know about whether there's an infection history in a knee joint and within the last 5 years. And as well, if there is such a history, a pre-treatment erythrocyte sedimentation rate, C-reactive protein, and synovial fluid analysis are mandatory. That we want to know if there's a history of radiation or chemotherapy in the last 5 years, because that may alter our approach to the patient. Last and more important is the skeletal muscular comorbidities of back pain, ankle pain, and neuropathies, because we don't want to treat a patient for knee pain when there's another source of referral. You want to know about the medications as well as the supplements. In the past, we were concerned about a patient taking statins. More recently, it doesn't seem to be of importance. As far as non-steroidal anti-inflammatories are concerned, the patient should try to discontinue them 10 days prior and for 3 to 6 weeks thereafter, unless they have polyarthritis, in which case you might have to make an exception and let the patient continue their anti-inflammatories. Next is the physical assessment. The BMI is going to be determined by height and weight. I then perform an orthopedic physical examination, starting with manual muscle testing to get an evaluation of the strength of the quadriceps muscle. And then as an orthopedic surgeon, I use a goniometer for range of motion testing of the knee and for measuring the mechanical access of the knee, that is the varus and the valgus. I then take out a tape measure and measure the circumference of the thigh, knee, and calf to create a baseline for comparison later on. Because as you'll see, sometimes the patient with subjective complaints has objective satisfactory results, and it's difficult to discern if your result is good or whether their patient is having a bad day when describing their outcome to a procedure. Next, watch the patient walk down the hall. If they're walking with an out-tone on one side, that suggests there's hip arthritis, and the pain may be referred from an arthritic hip rather than from an arthritic knee. Last of all, check the peripheral pulses. You don't want to buy into a patient who's going to wind up with an amputation because of a dysvascular process. The next thing I do is a data collection intake. And in my practice, I depended on my colleague Mary to do the intake, but those scoring numbers included the Knee Society score, which is a 100-point score based on subjective and objective observations, the visual analog scale, and the activity score. The lifestyle status of the patient pre and post are important to know. You want to establish a pre-treatment baseline, and let me give you an anecdote. A patient, a retired professor of ophthalmology, came to me for treatment of his knee arthritis, and I asked him, as part of the activity screening, how did you get here today? His response was, I can't walk, I have to take a taxi. How far away do you live? 6 blocks. He returned in 6 weeks for his follow-up visit, and I asked him, how are you doing? He said, lousy. It's a failed procedure. I wasted my money. You're a bad guy. I asked him, how did you get here today? He said, oh, I walked here. And all of a sudden, he realized what he told me. He smiled, apologized. He said, I guess I'm having a bad day. That's why the importance of documenting pre-treatment activity scores versus what you give them after the treatment. Last of all is the laboratory evaluation.
Dr. Sheinkop.
Yeah.
I'm sorry to cut you off. I was hoping you could expand on something before you move forward.
Yeah.
You did mention about the steroid injections and see if a patient had them within 6 months. Would you not perform the procedure if they had a steroid injection?
3 months.
3 months.
After 3 months, it's safe, but there's no question the patient is going to be worse off at some time prior to a steroid injection than, after the steroid injection than before. Initially, the local anesthetic that's used to expand the steroid provides anesthesia, and the steroid may have a positive effect. You do it a second time and you're killing cartilage, you're causing damage, and you're increasing the risk of infection. So I wait 3 months if there's a history of an injection.
For everybody else in the group, we do have some built-in time for Q&A. We are mainly doing it at the end. But if there is something pressing that you would like to ask Dr. Sheinkop, there is an icon that you can raise your hand. If you raise your hand, I'll find a good moment for him to take a pause and we can try to address that question. Thank you, Dr. Sheinkop.
Okay. So I'd like to have a CBC, a sedimentation rate, and C-reactive protein it's desirable, not mandatory. If the patient is healthy and young, you could skip it. If the patient is arthritic and over 70, they should be screened laboratory-wise. If you're considering IV sedation in conjunction with an intraosseous procedure, that is a subchondroplasty, you're going to require IV sedation, and in that case, the patient will be sent for pre-treatment medical clearance, and at that time, the laboratory studies will be completed. Now, a few red flags for treating with orthobiologics, and that is an abnormal CBC, that is an elevated white blood cell count, low platelets, elevated sedimentation rate, or elevated C-reactive protein. These issues have to be evaluated prior to treatment. You don't want to buy into someone who with multiple myeloma undiagnosed. Tobacco and alcohol abuse, we would like the patients not to be smokers, but maybe you could cut them down for 6 to 12 weeks prior to a procedure and minimize the alcohol intake. When you have a patient with a body mass index over 35.5, that's a real red flag. They're difficult to treat. One, to aspirate the bone marrow using an ultrasound machine can be difficult in obese patients. A fluoroscope becomes really helpful. And two, the outcome in these morbidly obese patients is not as satisfactory as those who are under 35.5 BMA. Lastly, the knee range of motion has to be analyzed. If there's less than 15 degrees of terminal extension and less than 100 degrees of flexion, they're a bad candidate. They're not going to do well. By the same token, varus or bow leg of over 10 degrees or valgus, that is knock knee of over 7 degrees, is problematic. And if there's evidence of instability on manual muscle testing, on stability testing, they shouldn't undergo a bone marrow procedure. Greg?
At this time, we want to open up the field to the floor to any questions. Is anything on anyone's mind, or anybody want to discuss anything that Dr. Sheinkop has brought up already? That's all right. It's a quiet bunch right now. All right, well, moving
questions.
All right, well, moving forward, Dr. Sheinkop, maybe we can discuss some of the patient-informed consent. How do you educate and prepare the patient for this procedure?
All right, so I have the patient in the room, and I actually show them the images, the x-ray, to show them the degree of joint space narrowing and let them understand how I am grading their knee, whether it's a KL2, 3, or 4, whether they have osteophyte formation, bone marrow lesions, and subchondral sclerosis. And then at that time, I introduce, if I find bone marrow lesions or subchondral sclerosis, the notion of an intraosseous intervention, that is subchondroplasty, in conjunction with the intraarticular aspect, as Ted had described in our published paper. I want to know about mechanical symptoms. Is the patient clunking in their knee? Are they giving way? Is there a pivot shift? That is a red flag for an MRI to make sure there isn't a bucket handle tear of a medial meniscus or an osteochondral loose body causing mechanical symptoms. And now the question will come up, what is the role of arthroscopy for these patients with grade 2 and 3 osteoarthritis, either before the intervention or 3 weeks thereafter? Interestingly enough, Ted and I sat in on a webinar for meniscal injury last night, sponsored by the American Academy of Orthopedic Surgeons, and it's quite a complex subject. But more importantly, a paper published on August 25th, 2023 in the Orthopedic Journal of Sports Medicine spoke about and addressed biologic augmentation after meniscal repair. And in the patient who had the augmentation using biologics, be it PRP or bone marrow concentrate, there was a better outcome, a better healing of an ACL, and less failure in the long run. Returning to the patient in the room, I go over the KO scoring. I try to encourage the patient to stop their nonsteroidal anti-inflammatories, try to lose a few pounds, and go start exercising. When you're dealing with a younger population of patients who are health club oriented or fitness oriented, that's easy. When you're dealing with arthritic patients older than middle age, you've got to motivate them. And the best way to motivate them is to send them for prehabilitation. That is to the physical therapist. They'll become familiar with the facility. They'll become familiar with the individual. They'll become familiar with the routine and what to expect after your procedure. Number two, in those patients I had highlighted earlier that may not meet the inclusion criteria because of altered range of motion, the physical therapist may restore better extension or more flexion, and now the patient who was previously excluded from having a bone marrow procedure will become included in the procedure. What are the objectives of what we do? Well, we're decreasing symptoms, not eliminating them, but decreasing them. 2, we're increasing function. And 3, we're postponing or avoiding a total knee replacement. That's our goal. This procedure, the bone marrow concentrate intervention, can be repeated. There's nothing wrong with alerting the patient. You may come back in 6 months or 6 years to repeat the procedure if you haven't attained the end result you seek. As far as the recovery after the intervention or reaching maximum medical improvement, it's a range. There's no specific time. It could be 6 weeks, it could be 6 months. And I'll cite you the example of a patient who did walking tours of Chicago, architectural walking tours. When he came to me, I did the procedure. He reported to me at 4 months. He hated me, sent me a nasty email, and was very disappointed. Yet 1 year, he sent me a love email telling me he had gone back to doing his walking tours, and he thanked me for enabling him. And the result was, because it took that long to reach maximum medical improvement. So it's important to alert your patients, this is not an anesthetic. It's going to take time, and you're going to have to work with physical therapy. Now I will address the treatment options for the patient and whether it's going to be an intraosseous, intraarticular, or a combination thereof.
Dr. Sheinkop, again,
yes.
sorry to interrupt you, but before you move on, I'm curious because I get this question a lot, and I get it a lot for the PRP, but from your experience, how long would you like to, what time frame would you like to see improvement in the patient after the injection? So for example, I know that one of our clinics that we work with will say after 6 months, if you don't feel at least 50% better after a PRP injection, they will administer another injection. What are your thoughts on that with the stem cells?
A reasonable question. One, you do a baseline. You follow up the patient at 6 weeks or 8 weeks to do an intake, assess their range of motion as well as their pain score. And sometimes that range of motion improvement will suggest that ultimately they're going to have a good outcome. In the back of my plan is a PRP adjunct. So if they come in at 6 weeks or 8 weeks and they're not on line to have the end result at that time we seek, I offer them a PRP booster. And that has proved very successful from the standpoint of goodwill and good outcomes. And many patients say that was the turning point, the follow-up PRP. Now, there are some clinics that actually include the follow-up PRP in their treatment protocol, and that's not a bad idea. So as far as 6 months, I think it's too long to wait. I think the best way to handle PRP is at 6-week intervals. With bone marrow concentrate at 3 months, if the patient is not where they want to be or where you want them to be, give them a PRP injection. Now,
how important do you feel post-treatment therapy is for these patients?
Mandatory to follow them up. It's not one and done. Don't think because you've done a procedure and you've gotten paid that you've done a good job. You have to monitor your patients, stay in touch with them. Remember, this is concierge medicine. The patients are paying good money for this. This is not being indemnified by Medicare or private insurance. They're entitled to good attention. Attention starts with returning their phone calls in a timely manner. If they're not satisfied with the staff's response, pick up the phone and call them back. Text them. I give my patients my email address, and they don't abuse it. I found it, interestingly enough, they don't abuse it. But I want them satisfied. And the best referral source for the next patient is a satisfied patient. Moving on, I talked to you about the evidence that supports the things we do. And I want to tell you about what Ted has compiled now in that follow-up of the 22 knees that we reported at 1 year. Now they're 2 years out. So The range of motion in 11 of those subjects had increased at 2 years. 4 of them decreased at 4 years. 1 of them was the same at 2 years. Or 4 had decreased at 2 years. Pre-treatment, their range of motion was 126.8 degrees, post-treatment 133 degrees. So they had picked up average increase at 2 years follow-up. And that's the importance of following them up. Aggressive strength training has resulted in a failure of 1 of those patients. 2 of those patients had elected to undergo a knee replacement cause of pain. One other had a knee replacement at 23 months, but while 18 of the 22 knees, or 82%, were still intact at 2 years. As far as the KL scores in those patients, 9 stayed the same at 2 years, 5 increased their arthritis level, 3 decreased their arthritis level. So what did we conclude from the trial? The quality of life in most of the patients improved. They were able to return to pickleball, walking, golfing, biking, fly fishing. The benchmark is a delayed, possibly avoided total knee replacement. So at that time, the patient will sign the informed consent. My recommendation is based on the history, physical examination, and image review. If you do the procedure now for the patient, and if it doesn't succeed, they could repeat the bone marrow concentrate. If in the long run it doesn't succeed, you have delayed a total knee replacement. For an unsatisfactory outcome of a bone marrow concentrate, you can do a total knee replacement. For an unsatisfactory outcome in 33% of total knee replacements, they require a revision total knee replacement. That's a lousy procedure. So now we'll talk about how we handle the issues financially. I've learned from the aesthetic and the plastic surgeons. It's a difficult decision to change from an indemnified by Medicare or private insurance approach to a self-pay option. If you're not comfortable doing it, have one of your assistants do it. But it has to be done. And after a period of time, discussing with the patient, you'll learn that they understand it. The best approach is to have your call center advise the patient, what we do is regenerative medicine. It's not indemnified by private insurance. It's not covered by Medicare. It's a self-pay option. Please understand that before you come to the office. Now, there are 2 exceptions. One is the workman's comp case, and one is the accident case, a tort case. In that situation, you will be paid by a third party, but it's going to be delayed. Now, the way we did it in our office, my receptionist would call the patient the night before, collect their credit card information over the phone, and prior to their coming to the office, all the economics were finalized. Some patient will make use of medical credit cards that are available. Some will use medical savings accounts, and some occasionally will want to schedule the patients. So what I would do is take 50% down. That covered my costs, my overhead, and then I'd let them pay it out on a 3-month schedule. I wouldn't do it if they lived out of state, because the collection people can't catch them. But if they live in state, practically, they're going to make their payments on a timely basis. PT prior to the procedure is very important. It could sort out other sources of pain, that is referred pain, the back, the hip, the ankle. Number 2, it prepares the patient for the surgery to maximize the benefit in the shortest period of time. When the patient is seen and treated post-intervention, Provide handouts in addition to verbal instructions, including your prescription for PT, and schedule the patient follow-up visit in 6 to 8 weeks prior to sending them home. You can do this verbally, and you do this with a printed handout, and you do this in the presence of the designated driver, because the patient themselves are going to only remember 15% of what you tell them. But if the designated driver is present, they could discuss it on the way home. So now we'll address the actual workflow and patient handling. Prior to the treatment day, a prescription for a sedative and an analgesic are called in. I like to give my patient 10 milligrams of Librium before the procedure. That medication cannot be administered until the consent is executed. But a little tranquilizer and sedation makes them happier. I give them a tramadol prescription for 3 pills should they have post-treatment pain, although it's really rare. It's unbelievable how little discomfort there is associated with the bone marrow aspiration when you're experienced and do it properly. If the patient's going to be done under IV sedation, then they don't need to miss breakfast. If there's an anesthesiologist involved and you're going to do this at a surgery center or with a traveling anesthesiologist, then they're going to be NPO after midnight. Once again, discontinue the NSAIDs 10 days before treatment and up to 6 to 12 weeks after treatment. Now, there are 2 ways of handling the patient based upon what I've told you, and basically what you find on X-ray, intake, MRI. It's either intraosseous or intraosseous intraarticular. The majority of your patients are going to be intraarticular, so they could be treated with oral sedation after signing their paperwork, a local anesthetic only for the skin and subcutaneous tissue. Avoid the local in the joint. It kills the cells. If the patient's going to be done with intraosseous care, then that requires IV sedation. You don't want to be drilling into the patient's bone with them awake. It's really unpleasant. When we're dealing with IA, intraarticular, provide the oral sedation, wait 15 to 20 minutes, and they're ready for the bone marrow aspiration. Make sure they sign the consent legally before you administer the pill. You position them prone on the table. You take your fingers and palpate the posterior superior iliac spines. They're really not hard to find. Then to take the ultrasound machine and confirm what you think are the bony landmarks. Then mark them with a skin scribe. Next, you scrub the back and prep it and drape it in standard fashion. And you administer local anesthesia to the left and right in the area of the posterior iliac spine. It's a readily available landmark. And if there's any question, my practice is to take a 1.5 inch 25 gauge needle for administering the dermal anesthetic, poke it into the skin and subcutaneous tissue, and then without putting any more anesthetic in, just use it to probe the posterior superior iliac spine. It's readily there, easily to identify with the needle. If you want to, you could use the ultrasound to help guide you. I haven't found that necessary many times. If it's a morbidly obese patient, it's helpful to have a fluoroscope available, because the ultrasound probably will not get you into the area that you want to identify. Now,
Dr. Sheinkop,
yes,
are there any potential adverse effects that anyone should be aware of anterior versus posterior aspirations?
yes, don't do an anterior aspiration. It doesn't make sense for several reasons. The richest source of bone marrow in the adult is the posterior iliac spine and the posterior superior iliac spine and the posterior third iliac crest. Hernigu has demonstrated that many times. for doing it anteriorly just never made sense to me. There's not the wealth of bone marrow to draw from. There's not the wealth of stem cells available, and it's more precarious. There's not as big a hunk of bone to penetrate. Stay away from the front, do it from the back. I mean the bone marrow procedure.
What about bilateral aspirations?
All right, so I'm getting there.
Okay.
Every case deserves a bilateral bone marrow concentrate, a bone marrow aspiration. If you're going to do one-sided knee, one knee, you take 30 from the left, 30 from the right. If you're going to do two knees, you take 60 from the left, 60 cc's from the right of bone marrow. Obviously, if you're taking 30, you have a better chance of having a large number of stem cells in the mix. But 60, now you want to advance that trocar, the Jamshidi needle, into the posterior third of the iliac crest, and that's not difficult. I mean, what you're going to do is take, after you've put in local anesthesia, and you take a little stab wound or a scalpel, and now you take the Jamshidi needle, and I like to percuss it in. So initially, the tympani is such, it's high pitched. Bing, bing, bing. The minute you bounce into the marrow cavity, you get a low resonance, and you know you're there. Number two, with an awake patient, they don't hurt. You're talking to them the whole time. If you're on target, they'll say, I feel pressure, or I don't feel anything. If you're off target, they'll hurt. So that's one of the advantages of local anesthesia as well. Now I use ACDA as my anticoagulant, and I use 10 cc syringes for aspirating bone marrow. 5 cc's are more desirable. It takes too much damn time. So 10 cc, not 20 or 30 cc syringes, but even Ted Sand was involved in identifying the volume of bone marrow per syringe. He did that with Hernigu, and he identified, correct me if I'm wrong, Ted. Am I giving you credit properly or no?
I did help write the paper, the manuscript that Dr. Hernigu published on his small volume aspiration. Yes.
Yeah, so small volume aspirations, you get a better draw, and 10 cc's is practical. 5 cc's is optimal, but it's impractical. Put in a little ACDA, aspirate. The only time you really have pain in this procedure is the first second you initiate the aspiration or the suction. The bone marrow is very sensitive to aspiration, but that passes in a second, and then the patient's happy. And the whole time you're talking to him about life in general. Now you've aspirated the bone marrow, you hand it off to your assistant, the person who's going to use the selling BMC plus bone marrow concentrate kit, and you're going to sit there and yak with the patient. The puncture wound you created with the scalpel for the Jamshidi needle need not be sutured. You put a dressing on it, turn them over on their backside. The pressure will stop any oozing. The assistant will come back in 25 to 30 minutes with the bone marrow concentrate and the PRP dilution. For one knee, it's 7. The formula is 7 cc's in general. So 7 cc's intraarticular per knee. Now, if the patient has an effusion as diagnosed by use of the ultrasound, aspirate it. They do better if you do that. You hold the patient after you've done you bring the assistant gives your nurse the bone marrow concentrate, you paint up the knee, you put on some sterile dressings, you put in local anesthesia. I prefer a suprapatellar anterolateral approach, guided with the ultrasound. I use an 18 cc for the injection, it's 18 cc syringe for injection of the bone marrow concentrate, PPP mix, withdraw it, put on a dressing, let the patient sit for a while, get dressed, get ready to leave, and now you call the designated driver and you go through the exercise of what I just did, what I expect for you. Here's your physical therapy prescription. Here's your appointment. The more you complete at that time in the presence of the designated driver, the less phone calls to harass your office. If I then ask my assistant to call the patient the next day to show interest and find out how they're doing, it is rare that a patient will complain of pain in their back or opposite the posterior superior iliac spine. It is rare to have ecchymosis or hematoma. It's if you get comfortable with the procedure, it's really a benign office-based procedure. Now, let's address the intraosseous approach. That's different. It can be uncomfortable for the patient and for the doctor who's causing the discomfort. Hence, I recommend the intravenous sedation. Occasionally, if you have an osteoporotic patient, you probably can do it under local. If you have a strong, thick-boned human being, you don't want to do a subchondroplasty with the patient awake. You want to do it sedated. Number two, as I don't want to forget to tell you this, one of the keys to minimizing their discomfort in something that's notoriously painful is once you place the trocar for administering the bone marrow concentrate PPP mix, first aspirate 5 cc of the patient's host bone marrow. Set it aside. Now you slowly inject the bone marrow concentrate PPP mix, 7 cc's. And as you're removing the trocar, you inject that bone marrow that you remove from the patient to make space as the chaser, so the bone marrow concentrate, the good stuff, doesn't extravasate from the intraosseous area. Okay, so when it comes to the intraosseous, intraarticular approach, the anesthesiologist is going to do all the preparation. You just walk in and you're the hero. So you're going to do the same approach for the bone marrow aspiration that I just described by placing the patient in the prone position on the table, cleaning them up, palpating the bony posterior superior iliac spine, confirming it with the ultrasound, marking it with the skin scribe, cleaning them up, draping them, aspirating them. You are going to take for one side, once again, 30 cc's and 30 cc's for one joint, 60 cc's and 60 cc's for two joints. The mix will be that for the intraosseous component, probably no more than 5 to 6 cc's of bone marrow concentrate or the patient's in too much pain. So you could spread it out. You're going to do intraarticular, they're getting 7 cc's of bone marrow concentrate with PPP. They're intraosseous, you're going to get 5 to 6 cc's of bone marrow concentrate with the PPP. For positioning the trocar for the intraosseous penetration, it requires a fluoroscope. You can't do it with an ultrasound. For the tibia, you're going to use the fluoroscope and use an anterior lateral tibial plateau or anterior medial tibial plateau approach. For the femoral condyles, you'll use a medial or lateral approach into the cancellous bone of the femoral condyle under fluoroscopic guidance. So place the patient on their back after the bone marrow concentrate's available, scrub up the knees. The anesthesiologist will take them out of Happyville and put them back to sleep with the IV sedation. Many of these patients will state, hey, this is just like the old days. This feels good. Maybe I should pick up my old habits again. And then you inject, you administer and put the trocar needle, it's a drillable device, into the subchondral bone at the area that you planned on from looking at the X-ray beforehand and the MRI to see where the subchondral sclerosis is or the bone marrow lesion. And accuracy is important for placement. Now, once again, when you're done administering the bone marrow concentrate and the chaser, you withdraw the injectable stylus, you dress the patient, you put them in a position of comfort, you bring in the designated driver, you discuss the procedure, you give them the handouts, physical therapy, the return appointment, and answer their questions. Follow up with the call the next day. I contact the patients, or I have my staff the next day or two, and then at 6 weeks, I'd like to see the patient a second time. Some practical aspects of what we do here. When you're getting started, 1 or 2 patients the first day. Once you get comfortable and your staff is comfortable, you have to respect your staff. They're an important part of this. Both the person who's the brewmaster using the selling bone marrow concentrate plus kit and preparing the material, and your nurse at the table, you have to respect them. So when you're getting started, everybody's a little bit uncomfortable. Once you've had a couple sessions for intraarticular injections, then you could do 4, maybe even 5 a day. It's a long day, but it works. If you're doing subchondroplasty intraosseous injections, then 2 a day max. The one thing that's the advantage, and I think Ted highlighted that when he reviewed our paper, is that at 2 and 3 years, the patients who've had intraosseous administrations are better off than the patients who've only had an intraarticular injection. I think I've covered most of these points that I wanted to emphasize, but I've had no adverse events. I have to tell you, in all the years, I've been doing this 13 years, and I've done a couple thousand procedures. I haven't had an infection, thrombophlebitis. I've never been called in the middle of the night. I've never been called in on a weekend. Once in a while, you have a patient who has some discomfort. Oh, I call them back, encourage them, remind them it takes time to get better, to recover. You won't reach maximum medical improvement. And the number one question, are you attending physical therapy? And the answer, well, I haven't started yet. You encourage them to comply with your recommendations, and you'll see big differences. You can restart the non-steroidal anti-inflammatories after 6 weeks. General observations. What types of patients do better? Patients under 35.5 BMI, pre-treatment range of motion of less than 15-degree flexion contracture and greater than 100 degrees of flexion. If the patient, when you first see them, do not have that range of motion, send them to pre-treatment physical therapy. Don't do patients with more than 10 degrees of varus and 7 degrees of valgus, and people on the extremes, on the margin, order an offloader brace. It goes a long way to relieving discomfort. So the patient who has any mechanical axis deviation, order an offloader brace. In most cases, it's covered by insurance and Medicare. Encourage the patients to communicate with you, and you communicate with them, and see them periodically to document results. If you have to re-intervene, as I said earlier, with a PRP booster, don't hesitate. So I think I've highlighted the points I wanted to highlight, and I think we have time now for questions.
Thank you, Dr. Sheinkop. That was fantastic. And I do want to reiterate a point that you said earlier, that this is all evidence-based medicine. I think the data out there is very compelling, and even more so, just hearing it out of your mouth is really beneficial. Does anybody have anything they'd like to ask Dr. Sheinkop at this time? All right, well, this call is scheduled to end. Wait, actually, we do have a question. Dr. Chowdhury? You can go ahead anytime.
Can you hear me?
Yes,
Now
we
I can. Now.
Okay. Hey, so, in my patients, I've been starting to use a lot of natural supplements. And these are boswellia, bromelain, tart cherry. I don't know if you've worked with them at all. I found them uniquely better. And I think patients acclimate to them a lot more comfortably, especially since I'm doing stem cells with them. We're talking about natural treatments. Have you had any effects, or have you utilized these natural supplements at all?
Well, I could answer that in two ways. No, I have no experience with these natural supplements, but I do take some every day. Now, number two, I sit on an IRB board, and the dominant thing that we discuss every 2 weeks is treatment for aging with all these things that come from the Amazon or come from Nepal or come from oat milk. But there's something to it, and I'm not opposed to it, and I think it's maybe very beneficial, but in all honesty, I have no scientific evidence to support other than anecdotal observation, such as you just described.
So I don't have anything that's going to make you younger or make you live longer, but but I'll tell you, I'm still looking for them right now. But the ones that I've utilized, frankly, were almost out of necessity, because we got to a point where we couldn't use narcotics for a lot of obvious reasons. Anti-inflammatories became also things that we were looking at causing long-term effects on, kidneys, blood pressure, cardiac issues. So we fell into a lot of these supplements that, interestingly, initially might have been discussed by patients, but then ultimately had some medical backing and some information behind them. But in terms of my patients with stem cells, it's been a nice relationship, and it's been a nice progression to be able to say, hey, you can have the stem cells, you can feel better. We had them off anti-inflammatories for 6 weeks, as you had recommended, and Dr. Laniewski had absolutely discussed with me in our conversations. But I never knew what to do with the supplements, because they still have anti-inflammatory effects. Interestingly, boswellia works on the lipoxygenase pathway, but anyway, yet to be seen as to whether, like, things like turmeric or other products, whether they affect the stem cells or not. I'm still not sure, but I do avoid them for 6 weeks after surgery. But I would love to use them along the continuum of treatment. It's just something that I'm waiting for somebody to say, hey, I've used both together and this is my time frame. I
We'll look
definitely
into
use
it.
them long term, though.
We'll look into it, but I want to tell you the best senolytic is the absence of pain in the improvement of function and recreation. So the bone marrow concentrate in the arthritic knee gets rid of the pain, gets the patient off the narcotics and the anti-inflammatories, allows them to improve their functional capacity and return to their pickleball or their golf or their tennis, their swimming, their biking, their fly fishing. So I think that's the best anti-aging activity, and happiness are the best anti-aging device. But I take your statement to heart, and I listen to patients tell me about these things they take, but I know nothing about it.
So, and I would like to say, I think I've been, when I started out doing this about 4 or 5 years ago, I did initially decide that I was going to test and challenge the models for who I'm doing these treatments for. and at least some of the people in this audience knew I started with morbidly obese patients, and it was phenomenal, absolutely phenomenal. I haven't been able to at least look at them without understanding that there was some failure ultimately because they were morbidly obese, maybe because they weren't as active. But the structural elements of what they did over 9 months, over a year, and frankly, a lot of them escaped from the trap of morbid obesity because of stem cells. And, they're forever thankful. And it's been very, very rewarding at multiple levels.
I appreciate your input, and it's something we will revisit. I find that patients who don't have self-control don't necessarily comply with the post-treatment recommendations. That's my problem. And a high number of them are diabetics, which is a red flag. But I've spoken to you personally. I know your feeling about this, and the issues that Ted and I are looking at now are 2 years and longer survivorship. 1 year is great if the patient understands it. 2 years is better. 5 to 7 years is best. But if you could do anything to those people to help them postpone or avoid a total knee replacement, you're on the right path.
Thank you,
The
Dr.
other thing that, one other thing that's interesting that we found out is, although, the endpoints for me were to avoid a total knee replacement, what's interesting is a lot of patients who had these stem cells ended up going from a total knee replacement. If they did go through the therapy and they still wanted to do something, we ended up doing a bunch of partial knee replacements. And it's interesting, the model became, I have all over knee pain, we've done the stem cells, and they became, interestingly, localized pain to the medial aspect of the knee or the lateral aspect of the knee. And they were great candidates for partial knees. So, there's a secondary input there that's not necessarily a failure, but it does give us a little bit, or gave me at least an alternative that converted them from a total knee to a period of time where they did well with stem cells, and then they backdropped into a lesser offering, like a partial knee replacement. Or frankly, we did do unloaded braces a lot too. So I appreciate you, having that conversation.
Your point is well taken. Anything you can do to improve the quality of life of a patient is a good activity. It's part of it is the informed consent. If the patient understands you're going to take a grade 3 osteoarthritis and postpone a total knee replacement, and maybe convert them ultimately from a total knee to a unicompartmental knee replacement. And maybe they'll have to take an extra strength Tylenol on occasion. That's a very good outcome. If anything you could do to decrease the possibility of total knee replacement, they may not be perfect, but they'll be a lot more functional than a lousy total knee outcome.
Thank you, Dr. Chowdhury. I appreciate that. And I think there's a lot to be said for naturally occurring, dietary supplements, whether they can be beneficial or harmful overall. I think that's a very good point, and I think we should look at that and discuss that further. I have one more question from the gallery, and I have some questions being typed in. One of the questions is, if the MRI indicates any torn meniscus or major structural defect, does that alter your approach?
Yes and no. I think if you have a major structural defect or an MRI with a bucket handle tear of the medial meniscus in a younger patient, arthroscopy for certain, then the bone marrow concentrates procedure. As I alluded to earlier, that publication that just came out the last week of August, it was compatible or consistent with repairing the defect and doing a bone marrow concentrate or some biologic in conjunction with. What's interesting is the idea of augmentation with biologic came to pass when the ACL was being repaired. The tunnel intraosseous allowed for extravasation of the contents of the bone marrow intraarticular. No different than if we were doing the biologics externally. So that's where the idea came from of augmenting the repair with bone marrow concentrate, occasionally PRP. So it's something to be considered. As far as the torn meniscus, it's such a complex issue. The way I break it down, if the MRI in a 55-year-old or older is going to be abnormal, and it is in 85% of patients, unless there's a mechanical axis, a mechanical symptom such as clunking, locking, giving way, I ignore it. If there is a mechanical interference in function, then that requires arthroscopic intervention. When we're dealing with people in the younger age groups, and I think you have to differentiate the abnormal MRI in a young athlete, a college, high school level athlete, a recreational enthusiast up to about 55 who doesn't have arthritis, from the patient who has the altered meniscal function in conjunction with arthritis. Those are two different animals. So if there is osteoarthritis and a torn meniscus, unless there are mechanical symptoms, ignore it. If there is not osteoarthritis and there's an abnormal MRI and you're pretty certain that the meniscal issue is causing the altered function and the pain, then it should be arthroscopically approached and augmented with bone marrow concentrate.
Excellent. All right, thank you. We have a question from Mr. Rocky Ray. Mr. Rocky Ray, please go right ahead.
Hey guys, thank you. Just a quick, curiosity, whether it be maybe in the clinic setting or point of care in the OR, do you find it an advantage to have a signaling to activate the signaling proteins, maybe with a thrombin calcium or something like that? Is that
outside of my knowledge base? I'll let Ted answer that. I've never done it.
Generally, in bone marrow, you have active cells, progenitor cells, that are sensing the environment and respond. And so additional activation, I don't think is required. PRP is a different case, and activation will set off the platelet cascade of secretions of alpha and dense granules and exosomes. So you might want to do that in a PRP, but I don't think it's, well, I haven't seen it done routinely, let's put it that way, on the BMC side.
okay? It's something that comes up from time to time, and then certainly when I'm in procedures, when it's spinal fusion, that's been a protocol and a process. So I just was curious to know.
Thank you. I personally am a firm believer in the activation of the blood just because of how the blood how the cells react within the clot. I think you're right in terms of, more exosomes, more activation from the cells. I think it's a valuable tool. But I just don't know how much literature there is out there to really, says that. But I do like the handling characteristics, and I think a lot of the physicians appreciate it too. Dr. Sheinkop. Yeah. Dr. Sheinkop, one of the questions that was texted in that I think is really interesting is, do you get a lot of questions about exosomes, cord blood, Wharton's jelly, etc.? What have you worked with and what have you seen?
Been there, done that. So in conjunction with my assistant Mary, we have published white papers, full scientific discussions on the use of umbilical cord collagen on the use of never embryonic cells, on the use of exosomes before we were shut down by the FDA with a warning for everybody, don't touch them. And now they're being tested for aesthetics, and I guess some people are using them off-label. Exosomes have great promise. Don't do it. You're going to get a knocking on the door by the FDA. Wait till it's authorized. And I have to tell you, with Ted Sands' credentials on everything, additionally, he is a compliance guy. He understands the regulatory pathways, and he'll tell you as well, don't touch exosomes at this time or risk going to jail. But they're good, and someday they'll be great, but not yet. So we'll stick with what is legal, what is FDA approved, and that with which we've had success. So yes, I've been involved in all kinds of orthobiologic studies. I would tell you that my interest is 2 years